Dr. Carpenter, over to you.
Thank you, Mrs. Dawson. It's a pleasure to be here for our first virtual XLH week. This is always fun for us, and I am happy to be able to moderate with my two fine colleagues, Doctors Emmeline and Sonia. Yes, the landscape has really changed. It's quite a story. It starts way back, nearly 80 years ago, when we became evident, when we first heard of this disorder, when it was evidenced as a treatment failure. Interestingly, the history of this disease has to do with a lot of treatment failures. The first name of this disease was in an article in the 1930s that you can go to a medical library and find. And this was called rickets resistant to vitamin D therapy. It's probably the first extensive description of the disease in the literature. And you can see, even when these doctors could do nothing but measure calcium and phosphorus in blood and urine, no vitamin D, no parathyroid hormone, no alkaline phosphatase even, no FGF23 levels. But with simple measurements of calcium and phosphorus, they could show that this patient had persistent hypophosphatemia, excessive urinary phosphate excretion, and upon removal of the parathyroid glands, we're able to show that mild hypertrophy of the parathyroid glands that we often see in patients with X-linked hypophosphatemia. This disorder remained being called vitamin D resistant rickets for many, many years. But about 20 years later, the further investigation of families with the disorder revealed that low blood phosphate levels were evident in the patients that had the so-called vitamin D resistant rickets. And with the shift of the focus of the disease from vitamin D resistance to the low phosphate level, the treating with phosphate became evident. So in the 1960s, really, in the early 1960s, replacement with phosphate became the standard of care for patients that were seen to have this. But we could see in the reports from those years some improvement in the rickets changes, but at a tremendous cost to hypercalcemia, parathyroid hormone elevations, and it just wasn't a tolerable therapy. So the next phase was to combine the phosphorus and the vitamin D, and this actually did a better job of treating the disease until about 1980, when it changed to the combination of the activated metabolite of vitamin D, calcitriol. During these years when the combination of phosphorus and high-dose vitamin D were the mainstay of therapy, a lot of patients got vitamin D intoxication, and because the doses of vitamin D were so high, and once given those high doses, because the vitamin D is stored in fat, you couldn't get rid of it. You couldn't escape from the toxicity. So the use of the active metabolite, which is not stored in fat, became a better approach, and that has been our standard of therapy. This is the story, really, of how we got to what we've been doing for the past 40 years with the disease. So to sort of summarize, we now see XLH as a disorder. If you look on the right side of this slide, the kidney cannot hold on to phosphorus, so there's an excretion of high amounts of phosphorus, and there's just a tiny amount of retained phosphorus that doesn't allow for the bones to mineralize normally, as shown on the left. But at the same time, there's this combined defect of the inability to generate the active metabolite of vitamin D, which is also something the kidney does. And these combined defects have been addressed by that combination therapy of calcitriol and phosphate, as shown in this slide. So this treatment over the past 40 years, as many of you know, has been a very cumbersome regimen, very difficult to adhere to. You have to give the doses many times through the day, and you have to be monitored and often change your doses when either biochemical or clinical features arise during the course of follow-up. We also know that this approach doesn't cure the disease, it helps management, and as we've stated, has its complications. So we've always continued a quest for better outcomes. And that has led to a new era. And that has been spawned by the identification of FGF23 as a mediator of phosphate wasting. And that identification has been important in terms of identifying a novel target for treatment. And then, of course, the development of such an approach to that by making an antibody that can inhibit the actions of FGF23 has led to this new era. With that, I'm going to turn the program over to Dr. Emmel, who is going to talk about what has changed in this new era. Eric?
Thanks, Tom. So I think that it's important to recognize that some things have changed and some things are similar, and that this is something I expect to be continuing to advance over time as we go along. So the first most obvious change in XLH right now has been that we have more medication options. Tom just spent a lot of time talking about what our conventional therapy for the last several decades has been, and that's been oral medications taken by mouth. And again, usually that's high doses of calcitriol, or in some countries, alpha calcidol. Calcitriol is usually given twice a day, and that's combined with high doses of phosphate salts, which were usually given about 4 times a day. But now there's another treatment option, which is Burosumab, also with the brand name of Crysvita, and that's an injection. So that's a big change in sort of how people are taking their medicines, but also it's a change in how often people are taking their medications for XLH. And I use the word medication on purpose because a lot of people will call calcitriol and phosphate a supplement in XLH, but I don't think of it as a supplement. I think of it as a real medical treatment because it has real medical side effects potentially. And so instead of having to take pills or liquid medicine several times a day, now we're giving children the option of Burosumab every 2 weeks as an injection, or adults every 4 weeks. But I think it's also important to recognize and remember that both do have beneficial effects on rickets. Certainly, as Tom illustrated, the time course, as we learned more about how to treat XLH, we got better and better at improving the rickets and the skeletal deformities. And it's important to remember, though, that in the Burosumab randomized clinical trial that we published in Lancet last year, that children were only eligible for that particular clinical trial if they were already receiving conventional therapy, and despite that, still had at least a certain degree of rickets severity. Basically, their rickets had to be bad enough, even though they were on medicines, to get in. And just as evidence that there is beneficial effect of conventional therapy on rickets, there was a very high screen failure rate. Now, what that meant here was 45% of the children that went through the screening protocol to test to see if they could be part of the trial, their rickets wasn't bad enough to be in the trial. And so that's evidence of important effect there. But what happened when we ran them through that trial? I think the first part is that here I've marked, hopefully nicely, with a syringe, the injections, and the pills, the pill bottle in red. So blue here is Burosumab, or Crysvita. And what we're looking at here is the fasting serum phosphorus here on the left. And you can see that on the conventional therapy, the fasting serum phosphorus changed a little bit, but not that much. Whereas if they got the Burosumab, it came up into the normal range up here in blue. So this dotted line is the normal range, and the serum phosphorus comes up into the normal range. Now, some of this variability is different time points after an injection. So it was highest 1 week after the injection when we measured it, and most of the rest of the time points are 2 weeks after an injection. Now, the other thing to remember is that the conventional therapy doesn't fix the fact that the kidneys are leaking phosphorus. And that's shown here by something called a TMP. And that level remained low, indicating that patients were not reabsorbing phosphorus very well if they stayed on the conventional therapy here in red. But if they got Burosumab in blue, the TMP, as a marker of how well they were reabsorbing phosphorus, improved into the normal range. And so I think that's overall very important. So it was working on the phosphorus by improving how the kidneys were handling it. And the reason for this is because Burosumab is binding and blocking the effects of FGF23. So now we have two different medication options, calcitriol plus phosphate. And I think it's important to remember that XLH should never be treated with just phosphate by itself. That causes a lot of problems. And so it always has to be combined with calcitriol or something similar to that. But with calcitriol and phosphate, we don't necessarily target a normal serum phosphorus level. And that's important because I think the higher your phosphorus level when you're treating with calcitriol and phosphate, I think that probably increases the risks of some of the side effects of that treatment. Whereas Burosumab, because of how it works at the and changes the way the kidney is handling phosphorus, we're able to target more normal phosphorus values. We looked at the rickets in those patients, and this uses two different scales here. So this little box here on the left, going up is better, and on the right, going down is better. But sort of with each scale, when we looked at the rickets at the growth plate here, and that's what this global score is sort of looking at, the patients in blue who were getting Burosumab, and these were children between the ages of 1 and 12 years, had bigger improvements in their rickets when they had switched from conventional therapy to Burosumab at the start of the study versus if they stayed on the conventional therapy. And again, on the far right, this is a different ricket severity score, and going down is better here. So again, the improvement is consistent. We also looked at the lower limb deformity score. So this was how badly bowed the legs were. And the magnitude of improvement over this time period wasn't as great. So it took longer to start to improve the shape of the legs than it did to improve the rickets at the ends of the growth plate, or ends of the legs at the growth plate. And so I think that's important as well. And then Dr. Insonia led a trial that was in adults, and in adults we gave them Burosumab or we gave them injections of placebo. And you can see here again on the phosphorus on the left, the adults didn't really change their phosphorus much when they were on the placebo, and it came up into the normal range in blue here when they got the Burosumab. After 24 weeks, the people on placebo switched over and were getting Burosumab too, so their phosphorus levels came up very nicely. One of the exciting parts of this study was actually the improvements in pseudo fractures or fractures. So on the right here, about half of the patients at baseline had active fractures or pseudo fractures that had not healed. And over time, as is not surprising, not very many of the patients on placebo healed those pseudo fractures and fractures completely during the 24 weeks. But during those first 24 weeks, 43% of the patients who had active fractures and pseudo fractures healed. And then during the longer term, the patients who crossed over to Burosumab again began to have more healing of their fractures. And the patients who had been on Burosumab the whole time, even more of them had complete healing. Now, one thing that I think is important here is that this number is 63% of the patients by week 48 had complete healing. The reason I think that's important is it's not 100%. So, normally, if you don't have XLH, people usually heal fractures or stress fractures, which are sort of the closest thing to pseudo fractures, a lot more rapidly than 48 weeks. They're usually healing them over the course of a few, several weeks or a few months. But I think that speaks to the chronic nature of some of these before they're found. And also that in XLH, the bone is abnormal enough that even with the treatment that has the most optimal effect on mineral metabolism, it still takes a long time for these bones to heal. And so I think that that's sort of a clue to me not to give up on those healing too soon. That if they're not healed by, a few months in, that doesn't mean that your treatment's not working. It just means it's taking a long time. And the other part of that is that in adults especially, although I've seen them in children, I haven't seen them very often in children. Pseudo fractures are these, what they really are sort of incomplete fractures. They don't go all the way through the bone. But they can be a chronic source of pain that patients don't know they have, and the doctors don't know they have unless they do radiographs. So, as a result of some of the studies that we were doing, we were discovering such a large number of people had fractures that they didn't know they had, and that nobody had known they had because they just had vague pain and hadn't had x-rays. I've really begun routinely in adults getting radiographs, especially of the lower limbs, at the start of treatment planning, and I have a lower threshold for getting them for complaints, what might have been more mild complaints later in treatment as well, just because patients may still develop new ones. I also think that in adults recently, there's been an increased awareness that there are treatment options. And so a lot of the standard of care for many years has been that many children stopped treatment with conventional therapy when they were done growing. But we always knew that some of them would have to go back on. And how long that would be was sort of unclear. And it sort of depended on how long it was before they began to have problems. And there was a lot of variability from provider to provider on how that was happening. But I think most kids were sort of getting a trial off of therapy around the end of growth or the end of childhood, when they became adults. But I think one of the problems there is that people forgot about that there were therapies that might still be beneficial for patients with XLH. And I think a lot of people fell off the grid until they were either breaking bones, having excessive pain, or they had children of their own with XLH. And so I think because of there being a new treatment option, there's actually more awareness in general in the XLH community, and also to some degree in the medical community, that there are treatments for adults. And so I think that's important. I think the other factor is genetic testing. Historically, genetic testing has been incredibly hard to get covered by insurance companies, but I actually think it's been more readily available now. And in some cases, that genetic testing is potentially free. And so that's something to ask your doctor about if that's a potential option. Now, some of this has been driven by the company that makes the medicine paying for genetic testing in some situations. But that is an added advantage, because as part of that, some people are getting the clear genetic diagnosis of XLH. But also some people are finding that that's not what they had, that they thought they had XLH, but they actually had a different gene that was the cause of their hypophosphatemia. And I think that's important as well, because different genes have different other effects that are important, and also can change what the recommended treatments would be. So I kind of wish everybody would have genetic testing if it's possible. I also think that there's an increased awareness among patients and clinicians about the complications of XLH itself, or the complications of the medicines that we give for XLH. And I think that's also beneficial to everyone involved. Now, what do I think hasn't maybe changed? Well, I think there are some factors about monitoring of treatment that are similar, and some things that maybe will change, although I'm not sure we necessarily want to change them just yet. I think we still need, I think there's two reasons. One, I think we have to recognize that with with few exceptions right now, almost everyone who ever goes on Burosumab was treated with conventional therapy for some period of time. Now, there's going to be a growing population that will only have been treated perhaps with Burosumab, and so. But the truth is, most people's children or adults right now still got conventional therapy for a period of time. I think we still have to watch dental health. Dental health is going to be very important. Uh, we are going to be looking at kidney function, kidney health, risks of nephrocalcinosis. There's a lot of blood tests still, and I think maybe over time we might find that it's okay to decrease how often we're doing blood tests. I think we still have to make sure that our patients are getting frequent blood testing to make sure that our treatment is effective. And again, that's whether you're on conventional therapy or whether you're on Burosumab. And then we're still going to be monitoring things like growth and the bone health. So all of that's still going to be very, very important. I think it's important to remember that the Burosumab or anti-FGF23 antibody treatment is not a cure for XLH. It's a treatment for XLH. And like most treatments, monitoring is important. So what do we not know? Well, I put this red crab on here because Tom likes to tell a story from his childhood about soft shell crabs, and so this is just a tribute to Tom. But what are the unknowns? What do we not know about Burosumab in particular? And I think the first thing is that what do we do know? We do know there's evidence to support improvements in the osteomalacia, or that poor mineralization of the bone, in the rickets, so the changes at the growth plate, the growing end of the bones. Some degree of improvements in the deformities in the lower legs. I'm sorry, the femurs and the tibia, just the legs in general. Improvements in growth, bone pain, insufficiency fractures, and fracture healing. I should correct that. I don't know that we have evidence that we have a decreased risk of insufficiency fractures, although that might make some degree of sense. What we actually have is that we have some evidence of improvements in the fracture healing. And probably improvements in muscle weakness as well. What do we not know? There's lots of things that are still unknowns, and Carl will end up touching on a couple of things, but what I'm going to focus on are, what about growth? So we have some evidence that the children who switched to Burosumab in the trial had some improvements in their growth compared to the children who stayed on conventional therapy. Those were not enormous increases in growth, at least when we looked at the average, but we're also looking at the average across children across a broad range of ages, some of whom are closer to the end of their growth period at the start of their participation, and some of whom were very young, at 1 or 2 years of age, who have a long time period potentially to grow. So what we don't know is how much more will being on Burosumab improve patients' height compared to being on conventional therapy. We do know that on conventional therapy, the average height of an adult with XLH is shorter than the general population. But how much of an increase will we get? It's important to remember Burosumab is not a growth hormone treatment. It's a treatment that improves the bone mineralizations, and any effects it has to improve growth are going to be through effects on how well the growth plates are doing and how straight the legs are and things like that. And on sort of related to that is, what is the full magnitude of effect on lower deformity? I said there's evidence of improvements, but how much will that be? How many surgeries in children might be prevented being on Burosumab versus being on conventional therapy? And we don't actually know that. We suspect there will probably be some, but what's the magnitude of that benefit? It's probably not going to be certainly everybody, but I do suspect that the kids who start younger will probably have a greater improvement there as well. But it's also important to know that there are probably some aspects of the bone and also of growth that are not mediated by FGF23 or phosphorus or 125D. And so those aspects aren't going to be changed by a medicine. What about nephrocalcinosis? So nephrocalcinosis is calcium deposits in the kidneys. Over long periods of time, they can cause some damage in the kidneys, and usually we see that in adults if we're noticing that. But even adults or kids will get nephrocalcinosis. And we know this is a risk of the conventional therapy and doesn't really appear to be something that patients with XLH who were never on a medical treatment at all got, but we do know that people on phosphate and calcitriol do get that. And so what we don't know is the risk of nephrocalcinosis the same as with conventional therapy if you switch to Burosumab, or is the risk with Burosumab less or more than with conventional therapy? And we just don't know that. The best I can say from my assessment of the various clinical trials that we've done is the risk doesn't appear to be more over what are, in the grand scheme of things, relatively short studies that may have only lasted a year or 2 years or 3 years, somewhere in that range, that it doesn't appear to be more than the risk with conventional therapy. Our hope is that the risk is less with Burosumab than with conventional therapy. But I do think it's important to know that one of the possible things that can happen with Burosumab is you can get your phosphorus too high. It doesn't happen to very many people, but I have seen it happen, that some patients will have their phosphorus go slightly above the upper end of the normal range. And if you don't have XLH and you get high phosphate, abnormally high phosphate levels, that in itself is a risk for deposits of calcium and phosphate in the kidneys. And so I suspect that the risk will still be, there will still be some risk with Burosumab, but our hope is that maybe it'll be somewhat less than with conventional therapy. But again, this is on my list of things I say we don't actually know the answer to. What about hyperparathyroidism? Hyperparathyroidism is very common in XLH, and it's kind of complicated because some aspects of it are sort of just due to XLH. Some aspects of it are due to the treatment with phosphate salts. And we know that PTH is worsened by treatment with phosphate salts. Some proportion of patients who get hyperparathyroidism begin to get high calcium levels. And that becomes more complicated to treat, and a lot of those patients need surgeries to remove parathyroid glands. Burosumab really shouldn't have the same risk as conventional therapy because the risk of conventional therapy for hyperparathyroidism is really driven by the phosphate salts. But and because of how Burosumab works, I think it shouldn't be expected to have the same risk, and it might improve it for some. And in the clinical trials we did in adults, there was a general, as a population, decrease in among the patients who had high PTH levels. There was a general trend to decrease PTH levels. Now, what I don't know is that will that potentially make the PTH normal? And the answer is probably not in everybody. And I think there's probably a time point beyond which patients might not be able to normalize their PTH. And that's probably especially in patients who have high calcium levels. And sort of in that regard, patients who have high calcium levels from hyperparathyroidism, I'm actually really cautious if I consider starting them on Burosumab. I usually start them on a lower dose than usual because I want to make sure that we're not accidentally making the calcium higher. But again, that's a gap in our knowledge that hopefully we'll learn more about over time. So here's another big factor is what about is this medicine safe in pregnancy, and is this medicine safe if you're breastfeeding? And the answer is we don't really know. The total worldwide experience of pregnancies in XLH patients getting Burosumab is extremely small. It has not yet been formally studied, although that is something that we are interested in studying. Pregnancy is obviously a time when a lot of people are adverse to considering uncertain risks. And so whenever you're doing something new, there's always risks that we may not necessarily know about. And the same thing goes for breastfeeding. And hopefully we'll be able to do the right studies over the next several years to be able to answer those questions. And that's actually very important to the FDA. The FDA mandates for most new medications that might potentially be given to reproductive age women that studies formally be done in order to try to establish, is it safe or not? Unless there's such compelling evidence that it's absolutely not safe, that you wouldn't even try to do it. But I don't think that's where we are with Burosumab. I think it's a place where it's information that we need that could help guide us for future treatments. And then, are there other long-term risks that we just don't know about with Burosumab? And I think that is something that takes a long time to sort of figure out. So with that, I'm going to pass things off to either Tom or Dr. Insonia.
So you all know Carl well. I'll, without further ado, pass on the baton.
Thanks, Tom. So I've been asked to comment on what hasn't changed and what has changed in the landscape of XLH, and a couple of disclaimers before we start. The first is some of the stuff I'll cover is redundant with what you've heard before, so my apologies for that. The second thing is that my practice is primarily in adults, so much of what I say will be relevant to adults in particular. And finally, some of my experiences that lead to my suggestions about what we should be monitoring with Burosumab therapy are based primarily on my experience in treating patients. Eric covered the data that we have based on the clinical trial data, but I think what I'm going to also try to cover is what my sort of in the field real world experience has been like. Okay, so what's not changed? Well, the cause of XLH has not changed. It's still a genetic disease caused by a mutation in an enzyme, and that mutation causes that enzyme not to function properly. And as you all know, that enzyme is called PEX. And it's still located on the X chromosome, and it hasn't moved from the X chromosome the last time I checked. So the basic physiology and pathophysiology are the same. And it's important to realize that the overproduction of FGF23 is a consequence of these loss of function in PEX. It's not understood how that happens, but we're treating sort of a downstream consequence of this mutation. We're not actually treating the mutation itself. So this schema of how excess FGF23, which of course is related, derivative to the mutation in PEX, leads to the changes that you have heard about several times. So if we start in the upper left-hand side of the slide, there's the PEX mutation in the DNA on the X chromosome. And that leads to an overproduction of FGF23 by a particular cell type in bone called osteocytes. And again, how that occurs, we still don't know. But what we do know is what's been covered already. When you have too much FGF23 production, if we now go first to the right side of the slide, that gray arrow leads us to the kidney. And in the kidney, there are these molecules that are important for reclaiming phosphate. And that phosphate is mostly healed. It's not me. I don't know who that is. That phosphate is mostly filtered and then reclaimed by the kidney. And that reclamation is mediated by these molecules, the sodium phosphate cotransporters that are shown right at the bottom of that arrow. And if there is a suppression in those molecules, if there's not enough of them around, then you don't reclaim the phosphate you've filtered in your kidney. And that leads to phosphate wasting and a low blood phosphorus, which is we go down from the kidney and take a left, you can see the low blood phosphorus. On the other side, if we start again at FGF23 and move to the left side of the slide, FGF23 suppresses the production of the active form of vitamin D, 125 dihydroxyvitamin D, and that leads to poor phosphate absorption from the gut. And then if we take a right from the bottom of the gut, it ultimately leads to a low serum phosphate. So there are two contributors to the low serum phosphate, the most important of which is the wasting of phosphate at the kidney. Somewhat less important is the poor absorption from the gut. And as I just sort of intimated, we still don't understand all the functions of the enzyme PEX. we still don't understand how loss of function in PECs causes overproduction of FGF23. And we still cannot actually cure the disease by replacing the broken PECs with a new PECs. That would be, the current types of enzyme replacement therapy that we hear about in diseases where there's a single gene mutation, usually in one of the cells in the bone marrow, that makes it possible. The problem here is that replacing PECs would require replacing it in tissues where we can't really do that yet. And we still don't know if blocking FGF23 with Burosumab will correct all the abnormalities in XLH. And what that relates to is concerns that the enzyme PEX has effects in bone besides those that lead to the overproduction of FGF23. It's kind of a long and complicated story, but some people think that with Burosumab, we are correcting the problem in phosphate, we are correcting the problem with vitamin D, but there are certain elements of the problem in bone that we can't reach with Burosumab. And whether that is true and whether that is clinically important remains an open question, which we can probably touch on a little later. So while we know that Burosumab greatly improves and in many cases nearly normalizes blood phosphorus, improves how people feel and function, helps heal fractures in adults, as Eric showed, we still don't know if it completely prevents rickets. We don't know whether it will prevent the changes in the skull that occur in a lot of children that persist into adulthood, like Chiari malformations. As Eric intimated, it improves the rate of growth in children, but we don't have enough data in children started at age 1 to know that whether it will completely normalize height. We know that conventional therapy makes dental disease less severe. We don't really know whether Burosumab will do the same. And again, as you all know, your teeth form early in life. So in order to have an effect on dental health, this is a drug that would have to be started very early in childhood. We don't know whether it'll prevent hearing loss. And the question that many adults have is, will it prevent the enthesopathy, a major issue in adults? And as a consequence of that, because Burosumab is a new drug that's really just come on the market in a few years, the burden of disease for people now living with XLH remains substantial. Older children are unlikely to reach normal height if they are much shorter than their peers or unaffected sibs when they start the drug later in adolescence. Dental disease is likely to persist in children and adults, again, because your teeth have formed, your secondary teeth, your permanent teeth have formed already. And difficulty with ambulation in adults will persist. And finally, hearing loss is unlikely to normalize. And what that means for my adult patients is you still need regular medical care. And you shouldn't ignore your disease and don't give up. Paying attention to the complications of the disease, seeking appropriate help may help to manage those complications and allow you to have a fuller life. And that includes orthopedic care and physical therapy. Hearing aids are very important when hearing loss becomes a major problem. And regular dental care is very important. As all of you know, there's a huge problem with dental abscesses. So regular dental care to stay on top of that, sometimes short of root canal treatment with antibiotics can forestall or even prevent the need for root canals. And exercising is very important. But obviously, it's important to spare your joints. I always try to recommend swimming first, and elliptical is another good alternative. Running is not a great option for young adults with XLH. And all that boils down to the hardest thing of all for all of us, whether or not we have XLH, is watching your weight. The more weight you put on those bones and those joints, the more problems will develop. So, what about emerging complications? One of the major problems, as I see it these days, is that with this new drug, which carries with it great promise and some uncertainty, patients are being seen more frequently by their physicians, and physicians are paying more attention to patients' symptoms. And so that is a term we call ascertainment bias. So we're seeing patients more often. So we're wondering more now about complaints that we would have passed off as just due to the disease. now beginning to be more cognizant of them and also wondering whether they're somehow related to the treatment. And that is perhaps no more evident than the frequent calls that I get about enthesopathy, and in particular spinal stenosis or symptoms related to disc disease. And this slide, which was a study, a cross-sectional study of a relatively small number of patients, if we just look at the enthesopathy, which is the middle column, and the spinal stenosis, which is the right column, and you move down from age 18 to 20 up through 60, and look at the numbers in parentheses, which are the percentage of patients studied at each age group that had that affliction, you can see that the incidence goes up. And it's important to recognize that these are findings that were either mostly brought to attention by symptoms. We really don't know how soon, for example, some of the early changes that will ultimately lead to spinal stenosis develop. So now that we're hearing more about people with back pain, and with these kind of data, we become more concerned about the development of this condition. And of course, as Eric intimated, we have no knowledge about whether Burosumab is going to prevent this, have no impact on it, or worsen it. The very limited data we have, which is looking at calcification of the Achilles tendon in the double-blind trial that Eric mentioned, we did look at, over that brief 1-year period of time, whether there was any progression in that one enthesopathy or that one enthesis, and there wasn't. But that doesn't tell us anything about long-term therapy. There's reasons to believe that maybe it would slow the progression. We can perhaps talk about that in the Q&A portion. And no particular reason to believe that it would worsen it, but it's a data-free area right now. So in terms of the things that we see with the drug therapy now, some of these things are things that I'm sure you've experienced yourself. There are some patients who notice a waning of the effect of the drug just before the next injection. Some people can say they can tell they're less energetic, they're more achy just before their next injection, then that that resolves. And that raises the question of whether, particularly in adults, you should reduce the interval with which the drug is administered. We don't have any data on that. Injection site reactions. Local injection site reactions are more common in children, and Tom can perhaps speak to that, but rash, swelling at the site is something that's seen somewhat more often in children than adults. One thing that is important to recognize is this drug, because it relieves the suppression and production of the active form of vitamin D, will lead to vitamin D deficiency to a greater extent in some individuals than others, but paying attention to the vitamin D level in the blood and supplementing is very important to prevent that from developing. And then finally, restless leg syndrome, which we saw with a higher frequency in the double-blind study at about 12%. And I clearly see this in some of my patients. Its etiology is not clear. It's a more complicated syndrome than I appreciated first. There are probably CNS contributions and neural signals that contribute to restless leg syndrome. And the treatment remains somewhat empiric. Iron deficiency will make it worse, so if the patient's anemic, that should be corrected. I've tried magnesium, and of course, you can also try dropping the dose if it's a major problem. And Eric alluded to this issue, which is difficulty treating patients who have high serum calcium and elevated blood parathyroid hormone, particularly if kidney function is not normal. So the FDA package insert says you should not use this drug with a creatinine clearance less than 29 mLs a minute, but I've encountered problems when kidney function is better than that. And then finally, this is my own personal experience. I routinely now check 24-hour urine calcium excretion at mid-dose in patients. And I have found that in some patients, that urinary calcium is high. So I have become concerned about that, particularly in patients who have a history of kidney stones or severe nephrocalcinosis. I don't have any data to say that the appearance of that, other than anecdotal experience, the appearance of that puts people at risk for stones. But in general now, I am checking that, and and moving more toward treating it, particularly in patients who have had a kidney stone while on Burosumab or have a past history of kidney stones and develop a kidney stone. And by treatment, I've tried both reducing the dose, which is my preference, or adding another drug like a thiazide diuretic to try and ameliorate it. So I think that's the end of my presentation. I think we're back to Tom.
Thank you, Carl. A few final comments, and then we'll get to some questions. They're coming in. Thank you all for them. So I just wanted to point out that there are some secondary changes in the XLH landscape that we're seeing. And I think a lot of this has to do with the excitement of a new therapy and the conversations that starts. And this meeting that we're involved with today is clearly an example of that. There's an increased awareness of this disease. There's a conversation that has gone on amongst patients. There's been educational seminars that have been put online. There's been increased visibility at meetings, and many physicians are much more aware of this than they were a decade ago. There's access to internet. There's social media. All of this has ramped up to such extensive degrees that the conversation has amplified, like with many other issues, but in such a way that the awareness is really out there. And some of that have been generated by a new therapy and the excitement around that. Some of that is that event in concert with the technological and social media advances that we're seeing. There's a number of groups doing natural history studies. There's a large one that is being sponsored by the XLH network together with Yale and Ultragenics called Beyond XLH, which is in early process and still under refinement, but hopes to engage many of you in collecting definitive information about the disease. And as Eric mentioned, there's an interest in the genetics, and there's a lot of knowledge that has come out of being able to identify in many unsolved cases what the genetic mutation is in unsolved cases of hypophosphatemia. The InVitae program has been the one that's offered at no cost, and if your insurance does not cover this, which is still the way it goes a lot of the times, you can ask your physician to participate in the InVitae program. So I think we've come to the end of the formal slides, and I think we've had a great discussion on how this landscape has changed rather dramatically over the past few years. And with that, I'm going to switch to a different computer where the chats are coming in and feel them out. The first one has to do with what are the effects of conventional therapy in pregnancy? I'm not going to go into individual history details of the patients here, but I think a general answer to that would be good. I'll field that one off to Dr. Emmel.
So it actually turns out there's very little that has been formally studied about the treatment of using conventional therapy in pregnancy. I think one of the important pieces of information comes from the study of the XLH mouse. And if mama mouse has XLH, both her babies before they're born have the ones that have XLH and the ones that don't have XLH all have normal serum phosphorus levels before they're born. And I think that makes sense because before you're born, your kidneys aren't really responsible for regulating your phosphorus. Your placenta is. And so that part isn't completely surprising to me. So my decision about whether to treat patients with XLH during pregnancy isn't actually based on the pregnancy itself, at least with conventional therapy. It's based on, does the mom need it for bone-related symptoms? But there is because there are a lot of hormonal changes during pregnancies that can change how vitamin D is handled, how calcium is handled. I'm actually more cautious in pregnant women even with conventional therapy, and I monitor their labs every month because I have found that I've had to sometimes decrease doses. And I have occasionally seen a patient have, either more nephrocalcinosis or more have some changes in their kidney function that were fortunately temporarily while being treated on conventional therapy. So I monitor them really closely so that I can catch anything early and make a dose change. But we don't have any data that says, is being on conventional therapy better for the baby or not? And we certainly don't have any information like that for Burosumab.
Thanks, Eric. A couple of people have asked about the risk of COVID infection in the context of vitamin D deficiency or with the consideration of the impaired vitamin D metabolism. And I can address that with the information that there have been a number of studies now that correlate vitamin D status with the severity of the infection. And some of these studies go in a way that show a correlation. There are several that do, and there are some that actually don't. So there's some controversy about that, but I think the way it is panning out is that if you try to put together most of what's come through, is that you tend to have a lower vitamin D level, and it tends to be quite deficient if you're not doing well. Now, that's not something that is peculiar to COVID. It happens in many diseases, and in many patients in ICUs, the vitamin D levels are low. A lot of that is likely related to acute illness, and the causal relationship there is not clear at all. So we don't think that any of these problems in XLH specifically have anything to do with an increased susceptibility to COVID. We do think that vitamin D levels need to be monitored, and in addition to the calcitriol therapy, supplementing with the usual doses of vitamin D that you would under any conditions if you're vitamin D deficient is reasonable. But there's no risk, and there's no need to handle this differently than in the general population. I think the one caveat that does arise is what Carl mentioned, that there does seem to be a tweak in the system with Burosumab, and that we are seeing some of the vitamin D levels drop. And so we have monitored that, and we do treat patients on particularly the Burosumab that have shown these drops, but nothing that increases your risk. The next question here is, can you talk about the potential side effect of spinal stenosis for adults taking Crysvita? And I'll pass that on to Dr. Insogna.
Well, as I sort of suggested in my presentation, we don't have data that speaks to that. I mean, when we talk about spinal stenosis, the cause is complicated. It can be due to progressive degenerative joint disease. Of course, the spine has joints in it that help one vertebrae move on the other. Those joints are often affected, and there's often extensive calcification around them. But the other complication is there are ligaments that lie above and below the spine that can be calcified. And we don't understand the mechanism by which those occur. There are sort of two philosophical views. One is that this enthesopathy, these calcifications, and we can think of it most easily if we think about the Achilles tendon, that what's happening is that tendon is trying to insert on a bone that's soft, that's mushy. And so the body's response is to sort of glom on more calcium to try to make that that structure more biomechanically sound. That's one hypothesis. And by that hypothesis, the line of reasoning would be that Burosumab would help mineralize normally so that you'd have less of that happen. The other hypothesis is that it's something related to PEX itself, not necessarily related to how much calcium or phosphorus is in the blood, but something related to PEX, and that you might suspect would not be addressed by Burosumab. The concern people have is, are you suddenly, because you're raising the serum phosphate, are you suddenly allowing calcium and phosphate to rapidly calcify these structures? And I don't think we have any direct evidence that's the case. We are not raising blood phosphorus to the levels above normal. We know that there seems to be a weak association between FGF23 and these calcifications of people without XLH. So maybe there's some direct effect of FGF23 to drive this. There may be other biochemical abnormalities that FGF23 drives, like a lowering of blood inhibitors of mineralization that could play a role. But I think that what we really need, and what I'm actually pushing for, is a study to prospectively look first at how much evidence there is for changes without there being symptoms in people, so that we can now look prospectively. I think, as I sort of intimated, this ascertainment bias is a confounder. People have always had back pain with XLH. Now they get back pain. And I should mention that sometimes the back pain is acutely worse when you initiate therapy. We've seen that more at 1 milligram per kilogram doses than we did in the phase 2 trials where we started at lower doses. So if patients develop back pain with initiation of therapy, I think it's a reasonable thing to drop the dose and then titrate back up. But at any rate, acute pain sometimes occurs in the back with the initiation of therapy. Physicians get imaging, they see this calcification, they see these joint problems, they say, oh my God, it's because of the Burosumab. But Eric, probably as Tom and I, have had lots of physicians call us with exactly that scenario. Had a patient started on Burosumab, had back pain within very early starting the drug, and they got imaging and they saw spinal stenosis. That seems to be very unlikely related to Burosumab. It's just the time frame is not quick enough. The unanswered question is, over time, are we going to see an attenuation or not? My own experience with patients who've been in the phase 2 trial and continued on therapy is it doesn't prevent it. Patients who've had bad spinal stenosis continue to have bad spinal stenosis. It doesn't prevent it. It doesn't reverse it, which is not surprising.
Thanks, Carl. For Eric, would Crysvita cause calcium deposits in the kidneys, which I think you alluded to, so you'll get the toss-up here, which is, can XLHers have osteoporosis?
So I did sort of mention about the kidneys that it is at least, theoretically possible that you could still get some degree of, nephrocalcinosis is sort of deposits of both calcium and phosphate in the kidney. That we know that calcitriol and phosphate have a risk of these deposits in the kidney. There probably is still some risk with Burosumab, and although I hope that it's lower, I don't have that proof, and so I don't know that. And like I said, there are some biological reasons, and Carl alluded to some of them as well, that especially if some patients are getting excessively high calcium levels in their blood or in their urine, that might increase the risk of that. And so I still monitor regularly with renal ultrasounds for calcium deposits in the kidney. The other question about osteoporosis is that's a harder one, partly because I think this all may change over time. Generally speaking, patients with XLH do not have low bone density. Generally speaking, patients with XLH have higher bone density than the general population. And there are complicated sort of reasons for that, and it's probably part of the body's response to the bone tissue being softer than normal for so long that it's trying to build more on to make it stronger. But I do wonder might we find more of patients actually developing, if we improve the bone over time with a medicine more directed at XLH, might people who otherwise would have been at risk for osteoporosis still develop that? And I don't actually think we actually know the answer to that. I would say that generally speaking, most of the medicines that are used for osteoporosis, I have always thought of those as not making any sense in patients with XLH, and with some potential for being harmful in patients with XLH. But some of that may change over time, and I don't know where that is going to end up going.
Thank you, Eric. A couple of questions have come through related to the response to Burosumab with not ideal phosphorus levels resulting from the phosphorus of the serum phosphorus level in response to Burosumab, and what does that mean? Should the doses be spread out to every 2 weeks, etc.? I think the answer to that is almost semantic, in that the basis is we don't know what level of phosphorus we need to achieve in order to heal the skeleton. I think rather than saying if you hit within a certain range, it's probably as important to see how much your phosphorus improved over time and what some of the other markers are of your skeletal situation that can tell us what the skeletal outcome is. With respect to dosing every 2 weeks versus 4 weeks in the adult population, I'll pass that on to Dr. Insonia, who sees more adults than I do.
I mean, the short answer is it's not something I've done. I know that some practicing endocrinologists have shortened the interval. What I have done, and I echo what Tom said, which is that so if you check your blood phosphorus at the peak of the dose effect, that's 2 weeks later, you should see that value come up above the lower limit of normal in most people. Then there's the phosphate you check just before your next dose. And the question is, if that level is very low, should you do something about that? I think as long as the peak value is within the normal range, I generally don't respond to that trough value, the value just before the dose. From a biochemical standpoint, I don't respond to that by shortening the dose. For patients who have the waning effect, as I just said, some physicians have shortened the dose to every 3 weeks. We don't have any data on doing that, so I'm reticent to do that. And I've heard from one physician whose patient who initially seemed to respond to Burosumab and then did not. So that raises the possibility that you're developing antibodies to block Burosumab. I've not had patients with that. So the short answer for me is, as long as people show a clinical response and show a bump in their serum phosphate at peak with a reasonable number at trough, even if they're having some waning of the symptoms, I won't shorten the dose. In rare circumstances, if it's low at peak, I will increase the dose. That I will do.
Thanks. I see that we're about 5 minutes over time. There are a couple of unanswered questions. I don't know what our constraints are, and I'll ask the organizers to let me know whether I should keep going or not.
I think if they don't say no, we can just keep doing it until they tell us to stop.
Okay, so I've heard that we should wrap up. There is a comment that we'll try to get these answered offline if we have to end now. The one question I will take is, we all want to know, where is your bow tie today, Dr. Carpenter? And I have to say, it's hanging up in my closet. It's Saturday. So thank you all very much. It was a nice to virtually be part of your session, and we hope to see you in person next time.
Thank you. Yep.
Doctors, thank you for your time, your wisdom, and your expertise. Our entire community is grateful to have you on our team, and we appreciate you giving up